Thanks very much for that introduction, Alistair, and thanks very much for inviting me to be on this panel. So it's really good to be here representing the views of oncology nurses. So the effect of oncology nursing of the pandemic has been extreme. Many of the things that we hold dear as nurses, certainly at the height of the pandemic, was kind of blown out the water, if you like. Things, as an example, we used to be able to even giving palliative treatments to patients, chemotherapy and immunotherapy, used to giving that with a degree of confidence, even if perhaps the chances of the patient responding were quite low. We knew that we could manage the risk of that with a good chance that they would be okay through their treatment and survive without risk. The pandemic changed all of that to the point where some of our treatments were curtailed. Some of our treatments were not started in palliative settings, and that led to quite a lot of distress and nurses being perfectly placed and having the skills to pick that up. So it was quite difficult when those things changed. At the same time, of course, many of the nurses, many specialist nurses, were dissipated throughout trusts and redeployed because we have skills that can be used elsewhere. So some of us went to ITU, some of us went to palliative care teams where we're talking to patients, looking after patients on ward with COVID. So it was all very difficult. We've now pulled that in a little bit, and nurses have returned to the cancer centres as we now await, as we spoke about earlier, quite a big backlog of patients who are coming back in. From my own personal practice, I know this is shared by many oncology nurses, one of the worst things about this thing has been the lack of visitors and support for relatives on support for patients on wards, where most wards have, most hospitals have curtailed visitors and relatives coming in to support patients. And that means that we're used to, as certainly specialist nurses, going to see patients and be able to discuss things with their relatives and those who support the patient, but those people are now very distant. So in my own practice, I go and see patients, for example, on an acute oncology ward round, and then go and repeat the round when I call the relatives and talk to people, often in very difficult circumstances, about their patients. Some of those relatives too will be shielding themselves and quite isolated and elderly. So generally speaking, it's been very difficult. I think that we are now pulling together, and we've had to innovate and come together as a group of nurses and share best practice in order to do that. And I think UKONS, the group I work with, has been very useful in doing that. The other thing, that one of the major considerations that other speakers have alluded to very strongly is confidence. And that confidence is that patients have confidence that if they come in and present with cancer, that they're going to be well looked after and be safe. And I think we've lost some of that confidence through the pandemic. We have to regain that. And of course, some of the people we've always had trouble reaching anyway. So people from the BAME community, we've always had difficulty reaching those hard to reach groups. It's even harder now. So we're going to work really hard to think about innovative messages to get out to people, to encourage them to come back to us, and that they'll be safe. And what other people have spoken about, the COVID light and sort of colder environments, will be vital in doing that. In terms of innovation, I think would I go back to the way things were pre-pandemic? No, I wouldn't. There's been lots of positive things come out of this. One of the major things is, of course, the use of technology, where patients they don't have to come in and try and park in a busy hospital. They can be seen by video link or by their own consultant. That's been really useful. It also, if CNSs and specialist nurses are not sitting next to the doctor in clinic, that frees them up to do other things, like to run their own clinics that they can innovate with. There's been an increase in nurse-led working, and of course, we can work on our own way of assessing patients. The other thing is that there's a big challenge out there, and that's because there's groups of patients who are shielding, and despite sort of lots of publicity about younger patients, cancer is a disease of the elderly largely, and many of our patients are quite isolated now out in the community shielding. So we have to innovate ways to reach them, and I think there's going to be something about getting workforce out there to look after them in the sort of post-COVID age. I think it's one of the other more positive things, talking about risk, is I think it's been very positive. There's been very frank discussions prior to treatments about what the risks of those treatments are, with respect forms and what the patient wishes would be if they became unwell. So I think it's really, really useful to have very clear discussions with patients, and I hope that will continue post-COVID. I think it's been very useful, and it's been very good from my own practice when people have come in and they think, oh yeah, I've already spoke about this, what might happen if I got ill? So there's been, it's been probably the most challenging time of my sort of getting on for 30-year career, but there's going to be good things that come out of it. So you know, whatever happens, I think the major thing is regain the confidence of our patients.
Love it. And I love the optimism. 30 years. Well done, Mark. Thank you very much indeed.